Welcome and thank you for joining us for today's AST webinar on individuals who are incarcerated as transplant living donor candidates, the ethical and psychosocial considerations. This webinar is hosted by the Psychosocial and Ethics Community of Practice and is supported by the Living Donor Community of Practice, the Kidney Pancreas Community of Practice, the Liver and Intestinal Community of Practice, and also supported by the Society for Transplant Social Workers. Before we begin the main presentation, we have a few housekeeping notes to help you engage in today's session. So currently on your screen, there is a viewership polling question. Please take a moment to answer this question while I finish the remaining announcements. This webinar is being recorded and the archive will be available on the AST YouTube channel in 2 to 3 business days. Please also note that your lines have all been muted so that only the presenters can be heard clearly for the archived recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Any questions that are submitted via chat may be missed during the presentation. And finally, when you log off at the conclusion of today's webinar, you'll see a link to a short evaluation survey. Please fill out the survey to help us keep our content current and engaging. Now I'll turn the session over to our moderator, Dr. Vineeta Kumar, to begin our presentation.
Thank you, Rafaela. Welcome, everybody, to our webinar today. This has been a culmination of a few years of work. The webinar, a couple of housekeeping things we want to talk about. During this webinar, you may hear a short abbreviated title IWAI, which is individuals who are incarcerated. And if we use that term, that's what it means. And these are the individuals we're talking about. We're limiting this webinar to talking about living donor candidates. We've already done a webinar last year on recipients, and we're not going to talk about incarcerated individuals as deceased donor candidates. So this is only for living donor candidates. We have some terrific presenters today. We have 3. Each of them is going to do a presentation between 10 and 12 minutes, after which we'll have a conversation, a dialogue with all of you. Our first presenter is going to be Farrah Desrosiers. She's going to go after I do a couple of overview slides that I've been asked to do. And Farrah has actually taken care of an individual who has been evaluated and gone on to donate, and she's going to share her experience of this, followed by Dr. Moritz, who was a transplant surgeon, has been involved in the care of a similar case a few decades ago, and he's going to share the history of that with us, followed by Dr. Lainie Ross, who's going to then help us think through an ethical analysis of when we consider patients in this category, or candidates in this category, what are all the contextual things we should be thinking about? So this is going to be a really thought-provoking topic for us, and it'll allow us to really examine our preconceived notions about prisoners who we think surrender many of their rights, including the right to choose their own destiny when they become wards of the state. Traditionally, there's been thoughts about them being vulnerable to coercion, susceptible to committing seemingly good acts for valuable consideration, and unable to give free and informed consent. Before we delve deep into this, a couple of reminders for everybody who's attending. One, the comments that our speakers are going to make today are not intended for quotes and dissemination to the media. And then the second is the purpose of this webinar, again, is for us to be able to engage in a respectable professional learning environment and dialogue about a very, very complex topic. Let's start off by this particular case that caught the attention and was the impetus. We started thinking about this in 2021. This actually was in 2022, where Ramiro Gonzalez was scheduled to die on July 13th for his role in a murder in 2001. And it was reported that this death row inmate was actually seeking a postponement of his execution so he could donate a kidney. And this started a huge dialogue again in an area where there was already conversation, including a 2013 New York Times article that had touched upon many of these debates that serious thinkers, ethicists, medical professionals, and prisoners themselves had differing views on this subject. Dr. Moritz's presentation is going to jump off of that. Around the same time as this very interesting act that the Massachusetts proposed bill had come up with, it was about incarcerated individuals being bone marrow and organ donation candidates. And this proposed legislation was to allow living donor candidates to receive between 60 and 365 days reduction in the length of their sentence, with the exact reduction to be determined by a committee of 5 people. Dr. Lainie Ross is going to go into it a lot more, but this bill had provoked extensive debate in the media and the transplant community about the ethics of commuting prison sentences in exchange for organs. And then finally, but not the least, this is a research letter that was in JAMA Network that reviewed at that point policies, what existed across different states. And they looked at 50 different states, including Washington, D.C., Federal Bureau of Prisons, and Immigration and Custom Enforcement agencies to see what was already there in the literature, or sorry, on their sites about what we would do with organ donation for individuals who are incarcerated. And here's a little blush of some of the states that had a specific policy explicitly stated. And 21 systems had an available policy, out of which 15 permitted living donation and 13 permitted registration for deceased donation. So with that background, some of the questions that we will be talking about in the presentations, and of course more as you ask these questions when we do the Q&A, will be something like this. So something basic as, can these incarcerated individuals even provide informed consent? What would be some of the ethical and social implications? Would NOTA allow for commutation of some of these prison sentences? And what do we as transplant centers and transplant care providers, what are our obligations in the well-being and protection of these candidates that are being considered? So with that preamble, I'm going to stop screen share and turn it over to my colleague and wonderful presenter, Farrah Desrosiers, to present her experience. And at that point, all of us will go off camera. So thank you, Farrah. Turn it over to you.
Dr. Kumar, thank you for the wonderful introduction. Sorry, my slides are loading to present here. Wonderful. And so I'm very excited to be here. And so I do want to thank AST as well as STSW and all those who are involved in putting this together today. So again, my name is Farrah Desrosiers, and I'm a living donor social worker and advocate at New York Presbyterian Hospital, Weill Cornell. And I've had the pleasure of supporting an individual who was incarcerated throughout the donation process. I don't have any disclosures to share. So I want to first talk about this patient who was introduced to me by my transplant colleague, and we'll call her Laura. And so one of my transplant coordinators had reached out to me, I believe it was by email, and she told me that we have a 33-year-old possible donor. They're hoping to donate to their spouse, and they're currently incarcerated, followed by, what do you think? And so to be honest, I didn't have very many thoughts about this topic because I had not really encountered any donors who had come forward who were currently incarcerated at the time of the evaluation. And I need more time to look to see what I could find in literature, or if my colleagues had experience working with individuals who are currently incarcerated, to have a better understanding on what to prepare or what I should know about as this person navigated this process. So one thing that I found to be really helpful in my understanding of what was maybe possible for this person was from a UNOS Ethics Committee statement that stated that absent any societal imperative, one's status as a prisoner should not preclude them from consideration as for a transplant. And while this quote is really looking at those who are going to be recipients of a transplant, I do think this could also be applied for those who are potential donors for an organ. I also went to New York State to see if there's any policy about those who are incarcerated and moving forward with this process. And so in New York State, I did find this directive from the Department of Corrections and Community Supervisions. And the policy, I do want to highlight a couple of things, that there was concern that for this individual, we couldn't assure informed consent. And because there may be a risk posed both to the donor as well as the public, there were policies that were written in order for someone to be able to proceed with this process from their perspective. And so for all living donors in New York State, they can only donate to an immediate family member for whom no other acceptable donor can be identified, and they need the approval from the commissioner. Additionally, I do want to also highlight the exclusionary criteria, which was that anyone who would come forward who was incarcerated, if they were not found to be competent to give consent, they could not be approved to give an organ. So then we continued. So Laura had spent 1 year gaining or trying to gain the commissioner's approval. And so when the coordinator had reached out to me about Laura, this is already 1 year after they had already gained approval from the commissioner. They were hoping to give to their spouse, and they both were in the same state. So they're both in New York. They were a compatible pair. And so in order to have the evaluation take place, it occurred on site. Hospital administration, security, transplant leadership, as well as security from the facility was all involved in this appointment. And the person who had come forward could not know the date of their evaluation. And so it would be a surprise to them before they came in. What was different about their evaluation process is that at my facility, each person who comes forward to donate, they complete their entire evaluation in 1 day. And typically they're able to we're able to move them around different rooms depending on what makes sense for the provider and the clinic flow at that time. In this case, this individual was in one room, and it was a room that was not with the rest of the clinics to the side. There was both hospital security on the outside of the room as well as on the inside of the room. There was 2 security guards, and the donor, was also there as well. And unlike my experiences with other donors, it was not one-on-one. So in my practice, that everyone that I meet with, I see them one-on-one. I don't deviate from that process. However, it was not possible because of safety reasons and security presence to have that be done. I met with them, and they were highly motivated to donate to their spouse. They had met their spouse prior to their incarceration, and then they had married their spouse during incarceration, and they were serving a potential life term, but they had eligibility for parole in the coming year and a half. But they were eager to proceed. They did not have any substance misuse history. They did not have any psychiatric history that was notable of any kind. It was pretty straightforward. However, again, I knew people one-on-one, so this was different. So I would assume that if this person had access to a substance while they were incarcerated, I'm not sure they would have shared with 2 security personnel from that facility during that time. And so there were some differences, but they assured me that they were willing to move forward, that they really loved their spouse, and they were hoping to help them have a better quality of life. Things that were also different about this process, before they had come in, there was somebody who was agreeing to pay for their transportation and security to and from the facility. When I asked this person about who that person was, it was their attorney, but they really could not share with me in a way that made sense to me why their attorney would do so. And so I do want to keep note of that. So some of my concerns or things that I was thinking about when it comes to Laura was Laura being exploited? And so Laura was incarcerated. They were giving to somebody who was not incarcerated. And part of, they have some vulnerabilities by being exploited, by being incarcerated. And the vulnerabilities that I'm aware of is what I have learned from, IRB approval process and how those who are incarcerated were known to be a vulnerable population. And then also I had these questions about why an attorney would pay for this person to come to and from the facility to our facility. I had thoughts about whether or not their sentence could be shortened because of doing this thing for their spouse, and so we had ethics involved. I also worried about their ability to give informed consent when they are currently living in a non-consensual environment, and so are they able to give voluntary, full informed consent? And then there were just some other risks that I had thought about for this person compared to the general population, such as what would happen if they had complications? Would they be allowed to come back to the center? Would the commissioner approve that? Would they still have access to this person, attorney paying for their transportation, as well as that they didn't meet the PHS guidelines? So things that shifted with Laura is that they had several additional appointments. We had several with about the risk of the process and how it might look different for them in terms of what if they weren't able to get here, what if they have complications, what if it wasn't approved by the commissioner. Additionally, I did ask the attorney additional information about their willingness to pay for this person's transportation and security. They had assured both myself and the patient that they were willing to, and there was no end date. And then on additional call with the patient, without the attorney, I explored with them how they would feel if they were unable to come back because the person paying for their security was no longer able to do so, and they were aware that it could be a possibility in the future. This person, Laura, had met all of our criteria for living donation. They had informed consent. It's not unreasonable for a spouse to want to give to their spouse, and so that I was able to follow their motivation. They had health literacy. In fact, this person was currently pursuing a bachelor's degree while they were incarcerated, and they had hoped to continue once they were hopefully released from incarceration. They did not have any ambivalence or significant ambivalence. There was no indication they were being paid to do this or they're being pressured to do so. And I think one thing that I thought about while working with this person was that whether or not someone's status, should there be a collateral consequence if this person wants to proceed with helping someone in need with an organ? And so how do you balance someone's autonomy and their right to make their own choices about their body? And so this person was able to donate. And they're doing quite well. They were released from incarceration, and they had called me maybe about 6 months ago, and they're doing as well as can be expected, but they're adjusting to being outside of the facility. And next, I'm going to hand this over to my colleague, Dr. Michael Moritz, and he'll be speaking next.
Good afternoon. I want to thank everyone for their interest and presence, without which we wouldn't be very successful. My current position is that I'm the PI at the Transplant Pregnancy Registry International. I have received, the TPRI has received grants from Veloxis and Stellus, and I've received travel support from Molly Pharma. No off-label use will be discussed today. What will be discussed today is a case that we published last month in American Journal of Transplant, which occurred a long time ago, and it was so offbeat, to be polite, that we hadn't published it, and until we heard that there in fact was a second or another death row inmate who was attempting to donate and was running into the expected administrative and bureaucratic problems. And so we decided to assemble this publication with obvious potential recall bias, as it occurred 30 years ago, to try and help some other people. I don't have consent from the donor, so we anonymized this as to jurisdiction, etc. And it occurred prior to the conditions of participation for transplantation, which were issued by the HHS in 2007. And for those, almost all of the audience, I'm reasonably certain, has not been in practice before 2007. Psychosocial evaluation was a nice thing to do, but it was defined by the program. There was no standard across the country. Could be anybody who did that psychosocial evaluation. There was no such thing as an independent living donor advocate. That had not been invented. You could donate wherever you wanted to. There was no stipulation in the COPs before the COPs on what kind of hospital or other facility you would donate at. And there was no obligation to report anything that occurred post-donation. So we're going to talk about an inmate in a state prison, in a state that doesn't have a transplant center. And we were approached by the prisoner's attorney regarding living donation to his mom, who was a patient at our transplant center and had a failing first transplant kidney and was listed on the deceased donor waiting list. The donor was on prospective donor was on death row, and so was his brother. And his brother was the one that opted to volunteer first, but was histologically incompatible due to mom being sensitized. And then the prospective donor opted to volunteer. In this jurisdiction, people on death row are in solitary confinement. Other restrictions on their freedoms include that their only physical visitors allowed were next of kin, clergy, and attorney. And there were no phone interviews except for those three groups of individuals. So through his attorney, he denied being asked to donate. He said he was volunteering. And equally importantly, he stated, and so does his attorney, that that there was no consideration at all that donating would change his legal status. The case that landed him in jail was infamous in that jurisdiction. There was no mercy coming from any quarter, irrespective of whether he donated kidney or not. All of this happened about a year after the original sentence. So we agreed, God knows why, but we agreed to consider him as a potential living donor. And we got the following concessions from the Bureau of Prisons. Same evaluation as if he were in our center through the medical staff at the prison. We got blood shipped to our HLA laboratory. That's how we knew he was histocompatible. Ultrasound and final anatomic study, which in that era was a standard arteriogram, not a CT arteriogram. They agreed to do outside the prison, but they were not going to let him leave the jurisdiction. So they weren't coming to our state. They were not crossing state lines. I don't know how many attorneys are online, but there's a thing called habeas corpus. So if you cross state line, if you leave the jurisdiction where you were sentenced, you can then file writ of habeas corpus in an attempt to not get extradited back to where you're on death row, or where you're incarcerated. So he wasn't leaving that state. So they agreed to do it at a hospital, which is known to be competent beyond the prison, but within their jurisdiction. And we got great cooperation from the prison medical staff. We got all his records. We got blood pressures and all the routine stuff. Weight. So we sort of knew what we were dealing with. Amazingly, the state agreed to pay for transportation and guard expenses, which includes all the excursions outside the prison, including the hospital stay. Once he was declared safe to return to prison, he would do so. Who made that decision? Prison medical staff, not me. And there he would continue his recuperation And they did agree to send us blood work at least one time post-donation. On the other hand, this was before there were virtual meetings. And so there was no face-to-face meeting until the evening before surgery. Now, that was in an era when living donors routinely were admitted to the hospital the evening before surgery. In today's era, that would not be possible. But regardless, myself as donor surgeon met him the evening before surgery. And as Farrah pointed out, it was not a one-on-one conversation. The other big problem with dealing with the Bureau of Prisons is they were appropriately concerned about escape attempts. And so originally they were going to give us the date and time of surgery and the place of surgery on 24 hours notice, but that doesn't work because you had to do a final cross match. So we got 48 hours out of them. And as to the hospital, we had to get temporary privileges, or I had to get temporary privileges to operate there. And that can't happen overnight. And so we got a 1 month notice of where we were going to do the surgery. They determined the duration of hospitalization. And it just so happens the two hospitals about, depending on traffic, an hour, hour and a half from the transplant center. I drove down there the night before. He was registered as a John Doe, shackled to the bed at the wrist and the ankle, and had 3 visible prison guards as his escorts. And in that circumstance, in that hospital room, I did his history, his physical, and his admission work, blood work and stuff, chest X-ray, EKG were all satisfactory. And we had our only informed consent discussion. And he signed informed consent on the hospital form and also on our transplant center form. It was surreal. Okay, so the Bureau of Prisons wanted to start a little ahead of time. And so we started on the night shift. So I drove home, had dinner, might have slept for an hour or two and then drove back. The guards came in the OR with him until he was anesthetized and paralyzed. And finally, the CRNA convinced the guards that they could leave. And they did. And the reason the Bureau of Prisons chose this old hospital was it had one of those old observation rooms. And so the guards went to the observation room to watch this affair, and then they could come back to the OR once he was closed for emergence from anesthesia. He had an open left nephrectomy. As I said, this was a long time ago when that was the standard. Might have been right around the year that the first laparoscopic living donor was published. The quality of the arteriogram was suboptimal, although I didn't recognize that until I transected a left lower pole artery. And also, again, and this is this is a long time ago, every hospital used its own homemade solution, and so did we. But we didn't for this procedure. We used UW because we knew that the cold ischemic time could be long. And there was no formal UNOS process for shipping. You triply bagged it and you put it in a cooler. And our transplant coordinator carried it from one institution to the other. Recipient was mom, second transplant, sensitized. The lower pole was reconstructed with the inferior epigastric artery of the recipient. And the kidney worked fine for 7 years when she died from a stroke, unrelated to everything else. So the one way that I thought to think about this is, okay, so we obviously made compromises, and are they forgivable or unforgivable is for each of us to decide. But a list of compromises that we made included no discussion between the potential donor with transplant coordinators, social workers, or even the donor surgeon until the night before surgery. The pre-donation visit and exam were way too close to the planned surgery. You know, at that point, what would have stopped it? Could he have stopped it? Could I have? It was clearly not a good time to be evaluating a potential donor. Obviously, we didn't have input into the venue or quality of the imaging studies, the OR environment. It's not like we did a practice run. I just showed up early. I can't remember if I brought my own retractor or not. I might have. Because not unless I had assurance that they had a suitable table-mounted retractor. There were no residents present. It was just a first assistant. And what assurance did we have that he was going to get good care after he went back to prison? Other than our faith and trust based on all of our communications with the medical staff that preceded this event. And what was your prison's interest in his long-term follow-up is a loaded question. So this happened about a year and a half after he was sentenced. 16 years later, so 17 years after the original sentence was passed, the donor dropped all of his pending appeals and pled guilty to second-degree murder in exchange for a defined period sentence. A few years after that, in this particular state, executions were ended and capital punishment was abolished by both judicial and legislative means, and all those on death row, which he was not anymore, were resentenced to life in prison without being eligible for parole. But he, of course, is eligible for parole because he has a defined sentence, and he will be eligible for parole in about 10 years from now, which will be about 40 years after his original sentence and 30 years after he donated a kidney. So a few quick lessons. Assumptions that we make about prison and prison life and sentences are just that. They're assumptions, and they may not stand the test of time. Obviously, the cooperation of the prison administration and the medical staff is key. The medical staff is the only way this thing can happen. And the interactions with the prison will test the transplant program's ability both to collaborate and be flexible. I don't know that most programs are very flexible at all. I want to thank the donor's attorney and the donor, of course, the prison administration, likely the governor, knew about it, and he may have been the one who authorized the state paying the cost of transportation and the guards. And of course, the prison medical staff. And we were questioned during the editorial process that led to that publication about why we didn't have counsel involved from the hospital. And that was the easiest answer ever. If we had gotten the institution, the transplant center's counsel involved, it never would have happened. Now, our legal consultant was my wife, who fortunately is a practicing lawyer appointed to the bar, and she provided the appropriate background. Thank you all for your attention, and I'll be available in a few minutes for questions. I'd like to now turn it over to my esteemed colleague, Dr. Lainie Ross, who's an ethicist and physician, in a much better position to discuss the ethical aspects of things. Thank you.
Thank you.
Lainie, you're muted there.
Yeah, and trying to get my picture. Hold on one second. There we go. So thank you, Michael. Thank you to the organizers. Thank you to the AST. Two wonderful stories to have heard, both being a donation between spouses and a son to a mother, which we'll talk about the importance from my perspective of first-degree relatives. And so both of those fit within the range where I think if we're going to be thinking about this, it's appropriate. But in the Q&A, I'd be happy to take questions about why I want to restrict it to first-degree relatives and of that sort. So without further ado, let's see if I can get my slides to work. Yes, my spouse owns stock. I will not be discussing unapproved or off-label experimental or investigational use. And my objectives are first to just give a framework for living donor organ transplant and apply it to individuals who are incarcerated. And then I want to specifically evaluate Massachusetts Bill 2333 in light of this framework. So this is a framework that I worked on with Dick Thistlethwaite, a transplant surgeon at the University of Chicago. And so we came up with what's called the 5-principle framework. And the first 3 principles come from the Belmont report, which is actually a report about research ethics. And there's a lot of similarities between research ethics and transplant ethics, because research ethics is done on a participant in order to benefit the whole population or third parties. And in a sense, being an organ donor is taking the risks in order to benefit a third party as well. And the 3 principles of the Belmont report are respect for persons, beneficence, and justice. And respect for persons is often understood as being understood as a component of the principle of autonomy and about being applied through using informed consent. And in our work, we actually said that rather than just thinking about autonomy in the individualist notion that we often do, a stronger way would be able to talk about relational autonomy, which is that the clinician and the patient or research participant are in relationship, and the clinician's job is not just to respect the autonomy, but to help the individual really understand their own values in order to make the best decision for themselves. Beneficence is always about the benefits outweighing harms and risks, and justice, we're going to take a justice is fairness approach and really think about it from an equity perspective. The 4th principle that we talked about in our framework was really developed through Ken Kipnis's work, again in the research ethics world, where he says that one of the problems with the Belmont report is that we talked about vulnerable groups. We talked about women, we talked about children, we talked about prisoners, and he wanted to move from vulnerable groups and argue that all of us have vulnerabilities at different times about different decisions. And he actually came up with a taxonomy of 8 different vulnerabilities, which I'll discuss on the next slide, as a much better way, rather than just assuming that all individuals who are incarcerated have the same vulnerabilities, for example. And the 5th principle that we used was developed by Robert Gooden, a philosopher who talked about when we think about vulnerabilities, it's also not like you have vulnerabilities in an atomistic sense, but again, that vulnerabilities are relational to the situation, relational to other people, but that relationship therefore create obligations. And so if you're vulnerable, there's somebody else who's responsible to help you overcome those vulnerabilities. And particularly in the healthcare setting, he said that special relationships create special obligations. And so with the Living Donor Advocate team having an obligation to reduce vulnerabilities in order to help donors act autonomously, again, in that relational approach. So these are the taxonomy, and that's where it is from the research. And what Dick Thistlethwaite and I did was then take these same concepts and apply it to the living donor transplant world. And so one way of being vulnerable is not having the capacity to deliberate about and decide whether to participate. Juridic and deferential are both about being liable to authority, juridic in a more formal sense, as you would see in a prison, deferential more in a family where children may defer to their parents and things of that sort. Social is about whether the potential living donor belongs to a group whose rights and interests have been socially disvalued. Situational is whether the potential living donor is in a situation where there's really no time in order to be able to deliberate. And that may be because we're in acute liver failure, or in the case that Dr. Moritz described, where really there wasn't the opportunities to be able to have these discussions with the living donor. The medical is whether the living donor is being selected in part because of a serious health-related condition in the intended recipient for which there are only less satisfactory remedies. And of course, that's almost always the case with living donor transplantation. Allocation is looking whether the potential living donor is lacking in subjectively important social goods, like their freedom, like their ability to have privacy, which is often lacking in prisons and things of that sort. And finally, there are the infrastructural. And we heard a lot, as Dr. Moritz was describing, about what would happen in post-op care. And so asking the questions of whether the political, organizational, economic, and social context of the setting possesses the integrity and resources needed to manage living donation process. So should we be willing to take a person to the operating room without the assurances of all of the infrastructural resources that will be needed after the donation? So specifically, I just wanted to talk about a few of these in a little bit more detail. One of the important things for Dr. Thistlethwaite and myself was that the Living Donor Advocate Team must ensure that vulnerabilities are adequately addressed. And they have to ensure that the donor is physically, psychologically, and emotionally healthy enough to donate. And one of the things I would add is that in our articles and in our book, when we discussed this, we also spoke specifically in the prison setting that the Living Donor Advocacy Team really needed to include a prison advocate. We needed that many clinicians, many social workers, if they're ever going to face, they're going to face one of these cases in their entire career. And so we need somebody who can help us understand the factors that are quite different when you are an individual who's incarcerated. And using that concept, we thought that the Living Donor Advocate Team is responsible for evaluating all the different types of vulnerability threats that the donor may experience and assure that they're adequately addressed in order to empower the donor to give a voluntary informed consent. And that we would argue is very important, a big change from what might have been done in Dr. Moritz's case, as well as we can go back to the 1960s when Tom Starzl was operating on prisoners as living donors as well. But I want to emphasize that I don't think that the Living Donor Advocate Team should protect potential donors from all risks, but they are responsible for ensuring that the donor is acting voluntarily with adequate information, and that in order for the transplant team to be able to morally justify enabling the donation. So what does it mean to address a potential donor's vulnerabilities? And I think this is really important, and those 8 different factors are really important. We have to reconceptualize autonomy and consent to empower donors to address their vulnerabilities through this relational approach to autonomy in order to really give a shared decision-making process. And by doing this, the Living Donor Advocate Team and other members empower the donor to understand the risks and benefits. They need to be able to acknowledge their vulnerabilities and determine whether they are adequately addressed. And so it's really important that this richer conception of autonomy, empowering the donors to more fully consider whether donation is in their best interest. And then to protect the individual donors when their decision is too risky, is based on inadequate information, inadequate understanding, or is otherwise not morally justifiable. So it's a pretty high bar that we're actually asking, and it's one of the reasons that we really support the whole notion of a Living Donor Advocate Team, which, as Dr. Moritz pointed out, didn't exist until around 2007. But that ability to have separate teams, that the team is really there for the well-being of the donor, because from a physical sense, we're talking about the risk to the donor, and so what are the benefits? And here we need to be talking about the psychological benefits, the emotional benefits, even sometimes the spiritual benefits that they may receive. So now focusing specifically on the prisoner as a living kidney donor. Again, looking in the research realm, what you should know is that the Belmont report was written by the National Commission. They also wrote a specific report looking at research involving prisoners. And they questioned whether incarceration truly allowed for free choice in deciding whether to participate in research. And I quote, "The availability of a population living in conditions of social and economic deprivation makes it possible for researchers to bring to these populations types of research which persons better suited would ordinarily refuse." So the National Commission concluded that given the vulnerabilities, they should only participate in research that offers direct benefit to the prisoners as individuals or to prisoners as a group. And so it's because of this report that you couldn't do any research in prisons. You had to only be able to do research that was going to benefit the prisoners or prisoners as a class. And so this shut down a lot of prison-based research. So nowadays, when we think of what research is done in prisoners, it may be being done about the transmission voluntarily or involuntarily of things like HIV, hepatitis B, but also infections like MRSA and things of that sort. So very much in not doing research, for example, to get the best acne medicine, just because you have a population that is constrained and therefore easier to do research on. So really very much focused on how does this serve the individuals who are incarcerated themselves. And so there's this real parallel, because in the 1960s and 70s, prisoners were participating as living donors. There were ads that were put out. Starzl had a connection in the prison. But then there was this 1966 CBA conference called Ethics in Transplantation, where many of the participants, other transplant surgeons, lawyers, theologians, all convinced Starzl that he shouldn't continue that. And he does report on some of his prisoners, one of whom did escape during the early years. Currently, our DOJ policy is that prisoners may donate to first-degree relatives only, and it's rarely performed, mainly because of logistics. And that's not an ethics argument, but the logistics are complicated, as we heard from both of the prior speakers. So again, looking at these 8 vulnerabilities, I've highlighted 2 because clearly prisoners are liable to the authority of others. And so we want to make sure when thinking about it voluntarily that it's not the prison staff who are suggesting it, or suggesting it that this is sort of an act of good behavior and can help them in any way. And of course, I really worry a lot about the infrastructural, whether we can assure not only appropriate medical care in donating, but also in the post-operative care. There have been attempts to increase organ and tissue donation by prisoners, and in January 2023, representatives from the Massachusetts legislature put forth a bill titled "An Act to Establish the Massachusetts Incarcerated Individual Bone Marrow and Organ Donation Program," offering somewhere between 2 and 12 months sentence reduction based on the estimated life savings of the recipients. The amount of time was determined by a committee of 5, only one of whom is designated to be a prisoner's right advocate. And again, I want prisoner right advocates on the Living Donor Advocate team. I would want even more representation on such a committee. But think about what these vulnerabilities are. I've already discussed the juridic and infrastructural when we're talking about prisoners as living donors, but there's a huge social. Given that the donation is expected to provide somewhere around 15 years of life to the candidate, it's interesting how the prisoners' lives are being valued or devalued. And that is a real social vulnerability, and reifying the structural injustices of the U.S. prison system, which is skewed to young, poor Black males. So here are my challenges to the Massachusetts bill. I think when we think about the vulnerabilities, it's not clear that the prisoners' vulnerabilities can be adequately addressed, particularly because this was looking for these individuals who are incarcerated to be donating more to the community at large and not to first-degree relatives. I have to think about the allocational vulnerability, because the potential living donor is lacking in subjectively important social goods that will be provided. So this might be viewed, therefore, as an undue inducement, that the idea of sentence reduction makes the opportunity too good to be true, making it very hard for the prisoner to say no. And so therefore, also violating the principle of NOTA, as I'll be discussing, which is the National Organ Transplant Act, which prohibits the exchange for valuable consideration. And clearly being allowed to leave prison 2 to 12 months early is a valuable consideration. There's also this notion of unequal opportunity, because not all who are incarcerated are able to donate a kidney, even if they wanted to, and they wouldn't be eligible for time off for, quote, good behavior. Donating bone marrow requires that you're HLA compatible, which means that individuals, since HLA compatibility does vary on the basis of ancestry, that this may again lead to some individuals who might be willing never being given the chance and therefore not having the same opportunity for prison reduction. But it also raises a different justice question, which is to ask, what is the purpose of incarceration? Is it general deterrence? Is it rehabilitation? Or is it retribution? Or is it a combination of the 3? I do think that allowing someone to leave because they donated an organ sort of ignores the purpose of deterrence. But I would say even more importantly, it ignores the victims or their families who may feel that a third-party tissue organ donation is irrelevant to the sentence that was decided to redress the harms experienced by the victims. And finally, I want to challenge the MA bill ethically because of its failure on respect for person. That sentence reduction focuses on the benefits to the recipient and not the risk to the donor. The idea that it's on the amount of time saved may mean that you might get more time off from being a stem cell donor than from being a kidney donor, even though we know that stem cells are replenishable and that there's a much greater risk from kidney nephrectomy than there is from taking bone marrow. So to conclude, the 5-principle framework can be effectively applied to individuals who are incarcerated. My ethical analysis supports restricted opportunities to donate. The current DOJ focus on limiting donations from incarcerated donors to their first-degree intimate relatives make a lot of sense. I can talk about more why in the Q&A. And this 5-principle framework would not support the Massachusetts proposal, in part because the payment or sentence reduction to incarcerated donors is undue inducement and contrary to NOTA. So thank you very much, and I'm looking forward to the Q&A.
Wow, fantastic. Thank you, Dr. Ross, Dr. Moritz, and Ms. Desrosiers for your fantastic, thought-provoking presentations. And we'll now open this up to Q&A. There's already been a robust discussion happening in the chat. Let me start off by just making this comment that living kidney donation, despite the risks of medical, psychosocial, and financial harm, is thought to be one of the most altruistic acts of humans. And then when you come to issue of individuals who are incarcerated as potential living kidney donors or actual donors, it's far from settled. But the two cases you presented, Ms. Desrosiers and Dr. Moritz, they really challenged the conventional norm. The conventional norm has been typically that prisoners are restricted from donating as living donors. And here you showed us that we were able to, in these cases, clearly move past that sort of preconceived idea. And so in the chat, there's some really interesting questions that have been brought up. And some of them have already been answered by Ms. Desrosiers and also by Dr. Thiessen. And I want to give a shout out to Dr. Carrie Thiessen. She's sort of the spirit and the life and the initiative and the intentionality behind this webinar. She's really moved this forward from a kernel and an idea to the 2 webinars that have happened on this topic last year and this year. So thank you, Dr. Thiessen, for that. So let me just group these questions together and start. I think Cindy Whipple started us on this question. Does the type of crime matter in considering somebody who's incarcerated for kidney donation? So in other words, if you are subjected to a capital versus non-capital punishment, does it make a difference? So capital would be a crime that is related to a death sentence, and non-capital would be like life imprisonment or fixed term or probation. Does that play into it? And I'm going to ask you first, Dr. Desrosiers, and then Dr. Moritz, and finally Dr. Ross, for your opinions and what do you know to be the case in your discussion?
I think it should have no impact. If someone is incarcerated, they already are serving their time for what they have done. And so there should be I don't believe there should be no collateral consequence by holding that for this process. I will say also intentionally, I did not include the details of my patient's incarceration, like the reasons why in the documentation outside of what need to be known by my colleagues. And I made sure not to talk about it at length because it's, again, we're not talking about what crime they had committed. We're talking about whether or not they were a suitable candidate for this elective surgery.
Thank you. But intentional collateral, I love the terms you used there. Thank you. Dr. Moritz?
Practically speaking, because it's such a hassle to evaluate a donor who's in prison, it's not going to happen except for people who have long sentences. So jaywalking is not going to provide you the opportunity to donate from prison. we would, I think somewhere around, I don't know, 4 or 5 years, less than that. You knew it was going to take a year or 2 or 3 to get through the prison administration if you were lucky. So somewhere anything less than 4 or 5 years, we didn't even bother, frankly, trying. We were like, they'll be out. When they're out, we'll be happy to evaluate them. On the capital side, though, something that Dr. Ross brought up has to do with who's the recipient. So many of the bureaus of prisons across the country have policies, and many of the policies restrict the recipient to close family members, as opposed to non-directed donation, or to lesser degrees of relation. And then you have to consider the impact on the victims of the crime, and do they have a say in whether this individual, as unrelated to their punishment per se, should be allowed to donate, and if so, to whom? So I don't think the original crime matters much, except in that second context.
Okay. So it takes a long time to get the evaluation done, so necessitates people being in for a longer period of time, and then the input of the people involved in their lives, the impact of that. Thank you. Dr. Ross?
Yeah, so I want to agree with both of my colleagues. I want to say so in general, the crime, whatever the crime is irrelevant, except in one concept, and that is about safety that we can't ignore. So the fact is that people who are incarcerated are not safe. Lots of rape and assaults occur in prisons, and so one of the concerns would be of infections. And we all know that in the transplant world, we ask people, we repeat their HIV and hepatitis status within several days of their being able to donate, and ask them to refrain from any risky behaviors between the time of the testing and the time that they donate. And now a prisoner can't, even if they say they're not going to participate, they may involuntarily be forced to participate in these risky behaviors. And so one question is, the only way that might be to protect them and their recipient would be to isolate them. And that may be cruel. And so, and the whole concept that you would be like in solitary confinement voluntarily is just like an oxymoron. And then if you really freaked out over that, telling the guards, well, listen, I'm not going to donate because I can't do this. I can't imagine the guards believing that anybody, again, is in the concept of solitary confinement voluntarily. So I think it does raise the issue when it's a nonviolent crime, and even if you're in for a long period of time, how do we protect you and your recipient? Versus if you're in for capital punishment, you're already isolated, so you're, in a sense, safer from the perspective of whether you're passing on infections. And all of that gets into, as I say, that's a medical vulnerability, just one of 8 vulnerabilities that we can talk about, but things that have to be considered if we're going to allow individuals who are incarcerated to be living donors in a safe way, so that the rules that apply for non-prisoners should be the same as those that apply for prisoners.
Absolutely. Thank you, Dr. Ross, for that. And Rupa Balamudi, your question should have been answered in the answer that Dr. Moritz gave. There's so many different directions we can go, and we are short on time, but I want to definitely take on this next set of questions. Some of them have been answered in the chat, in the Q&A box, and some we will answer now, but they're addressing sort of the post-donation outcomes, or the potential for ill outcomes for incarcerated individuals who go on to donate. So Dana Blaney asked about the psychiatric or psychosocial consequences post-donation, and Farrah, you very elegantly answered that. And by the same token, Lara Tushla answered, what happens, what is the CKD outcome in patients who are incarcerated, and would we be putting people who are incarcerated at increased health risk if they go on to donate, because they're going back into an environment that we're assuming, and what you alluded to already, Dr. Ross, and so did you, Dr. Moritz and Ms. Desrosiers, into a less than ideal environment, if you will. So while we may not have data, and Dr. Thiessen, you and your group have tried to find this information about incarcerated individuals, and you found it's incredibly hard to get that information. And if you'd like to come on camera and speak about that, I'll give you a chance. But I wanted to turn it to you, Dr. Desrosiers, just to speak about these post-transplant outcomes as you've been following these patients, and what are the concerns? And then to you, Dr. Moritz and Dr. Ross.
I do think that in some ways, a lot is different when someone is incarcerated. It's no different in terms of talking about theoretical outcomes of this process and seeing how they respond to those questions. And so in this case, I think it was no different that this person was posed with these questions. What could happen? We talked through what the options were, and then we had follow-up conversations to ensure that they could meaningfully understand how this could impact them. And were they willing to continue knowing that their process could look different in the future? And so I think that what had changed between my case and Dr. Moritz's case is that there was opportunity to kind of have these discussions over months' time. And so there were several conversations regarding this process. Whenever there was a new way it could change for this person, it was another follow-up discussion with that same person about this could be different for you. What does that mean to you? And how might, what would you do in this case? And what could you do if I couldn't help you? In terms of, I can't get the commissioner to approve their release for a complication, right? And so there might be some limitations to my scope in this case.
Thank you. Dr. Moritz, what, if anything, do we know about outcomes in general for incarcerated individuals, let alone donation?
We're obviously the early post-operative period in terms of a week or two, even with minimally invasive surgery and less narcotics or no narcotics, is still debilitating physically. And such an individual would be at significant risk for assault in an unprotected environment. Hence, they always go to the infirmary, but I'm not sure an prison infirmary is the safest place to be either, obviously. Long-term, it would appear, lacking experience, it would appear that is a high-stress environment. A variety of bad behaviors are not discouraged. It's a high caloric diet with problems of overweightedness. I don't know the incidence of hypertension in men who are incarcerated. I mean, under the heading of all the things that prisoners have to worry about, CKD may not be last on the list. Maybe it's just next to last.
Wow. So the incidence of CKD is pretty high, is what you're telling us for all.
No, I have no idea what it would be.
We don't know.
In those who are incarcerated. Does it progress? Would CKD progress more rapidly because you're incarcerated? I have no idea. And I don't know that there's any data on it, since the prison population in the U.S. is so skewed ethnically. It's not reflective of any other population in the country. But they're just more proximate concerns for individuals who are incarcerated than access to than CKD care or avoiding ESRD.
And so I'm gonna surprise myself and say, so I agree with everything you just said. And yet here in the notion of relational autonomy, if they have capacity, right, and they're not capacitationally vulnerable, that's something to discuss with the potential donors. What are the risks and what are all the unknowns, which are much greater in that population than it is in another population? And yet still, to the extent that we can get to a point where they can say that the benefits outweigh the risks, but we just need to be very upfront about the ways we can't protect them, the ways that they may be physically putting themselves at risk. And yet from an autonomy perspective, I would still say, again, donating to a first-degree relative, which is really what we're focused on with the two cases, it still could be permissible, with one caveat, and I really think this is a really important caveat, that we really have to make sure that we have the resources in the prison. Like you already mentioned, Dr. Moritz, we might be doing this without opioids, because bringing opioids into a prison is going to be a really controversial thing. We're going to be putting them in an infirmary where it's not the safest place. And so if we can't guarantee appropriate post-op care, then I'm not sure it's appropriate for us to expose them to any of these risks. And so that's something that we as a community really have to decide how we're going to deal with that post-operative, particularly that the first 2 to 3 weeks, even with laparoscopic.
You know, if we're 4 minutes over, we still have 183 people on. So it's telling us that we're just barely scratching the surface and what an important topic this is. But, you know, all good things must come to an end. So in wrap up, I want to make 2 comments. One, Dr. Thiessen shared in the chat really to the panelists, and I'll just read it out. She wants us to make sure the PSECOP is working on the incarcerated individuals as transplant candidates and recipients. And the result of this is that we were not able to identify a variable that would help us identify them in SRT or recipient data fields. And the assumption is that it would probably be the same would be true for living donor data fields. And yet, as we have had these conversations, we have had 2 people that are here today in this hour presenting their cases. More of you who are listening who've actually either had a case that you've been working up or have seen it through. So here's an opportunity for us to come together. I see comments about wonderful presentations, and that we'll hopefully do a part 2. And essentially the end of this is that if we have been in this space that we sort of, anytime a incarcerated individual evaluation comes up, we sort of draw the line immediately. Perhaps this hour allows us to think as transplant centers, caregivers, policymakers, to at the least reevaluate our eligibility standards and think about if there were strict ethical and legal oversights and policies, would we bend that needle or change that trajectory just a little bit? So with that, I would love to thank, first of all, our amazing presenters who got us thinking in this direction, our participants who came and stayed on with us, and then to our AST staff. And I turn it over to you, Raf. Thank you very much.
Thank you, Vineeta. First, we would just like to thank the PSECOP for hosting this session. And on behalf of AST, we would also like to thank our speakers and moderators and all of our attendees for joining today. And finally, for our attendees, please remember to complete the evaluation survey that will be sent to you shortly, and visit www.myast.org/education to learn more about and register for our upcoming reminders. The recording of this session will be available in the next few days on the AST YouTube channel. Thank you again for today's session.